Thank you for joining us for tonight's educational webinar on total ankle replacement. Tonight's speaker is Dr. Jeff Gittins, OrthoNeuro Orthopedic Surgeon. Dr. Gittins is a board-certified orthopedic surgeon with specialized training in orthopedic sports medicine and adult foot and ankle reconstruction. Please type questions into the Q&A box below, and Dr. Gittins will answer questions following his presentation. Dr. Gittins?
Thank you. Let me pull my screen up here. Thank you all for joining us for this webinar about ankle arthritis, truly, but we're going to talk a little bit about how to treat ankle arthritis with an ankle replacement. Start way back at the beginning regarding ankle arthritis and how it is treated initially with conservative care and what ankle arthritis is. So what is arthritis? It's a Latin term, arthros meaning joint and itis meaning inflammation. With arthritis, it's a leading cause of disability in the United States. It's an inflammatory response within joint space. Tonight we're talking about ankle arthritis specifically. There are several different types of arthritis, but all lead to ultimately destruction of the cartilage within the joint space. There are various types of ankle arthritis, including osteoarthritis, one of the most common ones, including rheumatoid arthritis. There's several forms of rheumatoid arthritis, but there's also post-traumatic arthritis. With osteoarthritis, there's wear and tear of the joint space. It can be slow and progressive loss of cartilage. There is an inheritance pattern with this as well. With rheumatoid arthritis, there's an immune system which is destroying the cartilage within the joint space. It leads to many joints being attacked at the same time. The joints are typically swollen and deformed as well. And with post-traumatic arthritis, the patient usually has a previous injury to the ankle, whether it be an ankle sprain or a previous ankle fracture. This may occur months before arthritis takes place, or it could be even years. With arthritis, the normal cartilage has a nice, thick cartilage layer that is supported by the periosteum, but also normal bone, which is the understructural body, which supports the cartilage, and the blood supply comes to the cartilage from the bone. When arthritis takes place, especially with osteoarthritis, cartilage fragments, it forms flaps and becomes irregular borders. Loose bodies can be knocked off and float around the joint space. You can have flaking and erosions of the bone underneath, which leads to cyst formations as well. This is another picture depicting a normal joint space versus a abnormal joint space where arthritis is taking place. And just by visualization, it just looks angry. Once again, there's an inflammatory response within the joint space. The synovium itself, which is a lining within the joint, becomes thickened, it becomes inflamed. The nerve endings are very sensitive. Because of arthritis and destruction of the cartilage, abnormal stresses can be applied to the joint space, which leads to bone spurs forming or osteophytes forming around the joint spaces. This can form the subchondral bone because the cartilage has been disrupted and the fluid within the joint space gets pushed down in the bone, forming a cyst. These are all destructive means of arthritis. Here is a cartoon showing arthritis with the normal cartilage. It has a smooth appearance. It allows for a smooth articulation versus an arthritic joint space where the cartilage is damaged, it's cracked, it's fragmented. It shows pain with range of motion as well as activity, especially when weight bearing. What causes pain with arthritis? It's the damage and the flaking of the cartilage. Bone on bone contact can give pain as well. Bony spurs or extra bone around the joints can cause decreased range of motion as well. When the cartilage flakes off, it can give people symptoms of locking or catching or symptoms of instability to the ankle joint. With bone on bone contact, it's a grinding sensation that can have swelling. The patient can have stiffness. It gives them a deep gnawing toothache sensation at times. The ligaments themselves can loosen. It gives them a sense of instability. And with the bone spurs, they don't feel like they have the same motion. When they do get to the end of range of motion, it causes pain when the bone spurs collide against each other. Other symptoms of arthritis include pain and stiffness. Pain tends to be worse with prolonged exercise and activity. Pain can be also worse with the first steps after resting. With stiffness, there's morning stiffness, which seems to be the worst of all. The joint is stiffer and harder to move over time. There may be swelling at the end of the day. The joint feels unstable once again. Symptoms of weakness that just wants to give out. The patient just can't control it. There's episodes of severe pain with blocking of the joint space at the end stage of arthritis. When we look at x-rays, a lot of times when we're ordering x-rays, we're not really looking for any type of fractures or things. Although on this cartoon, it does show you the patient on the left-hand side has had a previous fracture. But when we're looking for arthritis, we want to know what the stability of the ankle joint is, the biomechanical axis, how well does the joint line up. We want to know if there's cartilage left in the joint space. Now, we can't see cartilage on an x-ray, but we can see where cartilage is being worn down by the imbalance of the ankle joint. On the right-hand side, it shows an x-ray of mild arthritis. There's bony spurs forming in the lateral compartment of the joint space, and overall the joint space is slightly decreased. When we look at other x-rays of more moderate arthritis or even severe arthritis, we see more exaggeration of the arthritic response. On the left-hand picture, there's a decreased joint space, but only on one side of the joint. Joint wants to tilt ever so slightly with the ankle bone. Versus on the right side, there's severe arthritis. The arthritis is neutral. The bone is completely collapsed on itself. There's subchondral cyst formation as well. Now, we don't really get MRI scans because of arthritis, but in this case, the arthritis, if it's a mild case, sometimes we're trying to figure out if we can treat the arthritis without leading to a more advanced type of surgery. Here we're seeing subchondral bone irregularities, not only to the ankle bone called the talus, but also to the roof of the ankle called the tibia. And this is more drastic because it's involving both sides of the joint space. Our treatment goals when it comes to arthritis is trying to relieve pain and inflammation, slow down the progression of the disease. We look to improve the quality of life. We also look to restore and maintain functional independence. There are several options when it comes to conservative care of treating ankle arthritis. That includes different types of medications, lifestyle changes, physical therapy, bracing, and then sometimes it leads to surgery with advanced cases. With medications, we include pain relievers. Most often we do not, once again, we do not use opioids, narcotics, or even tramadol, but we usually rely upon the non-steroidal anti-inflammatory medications, including the COX-2 selective medications like Celebrex, or the non-selective anti-inflammatory medicine like the ones you would normally see over the counter, as in Motrin, Advil, or Aleve. Some nutritional supplements can be of benefit, including the glucosamine chondroitin sulfate, as well as fish oil and vitamin E, which act as antioxidants. Joint injections can be of benefit. Those include corticosteroid injections, possible hyaluronic acid, as well as platelet-rich plasma injections, as you see the question marks behind them. I have found hyaluronic acid to be a very useful means of trying to control pain and dysfunction with an arthritic ankle, but unfortunately many insurance companies do not cover it, therefore it will be a cash pay. We're still trying to figure out the exact application of platelet-rich plasma as it pertains to ankle arthritis. What we don't know, what we can't control, is the platelet-rich plasma and how it's prepared so we can deliver the best dosing, if you will, of the platelet-rich plasma. This is a screenshot of a patient who's getting an injection, showing how we're isolating the injection near the tibialis anterior tendon. You can see bowstring it ever so slightly at the joint space. When we talk about controlling arthritis, the pain and the dysfunction, lifestyle changes have to be entertained as well. Avoiding of impact activities is paramount. We have to go away from running the impact aerobics and treadmill. That's very stressful to the joint, causing compression along the joint space, and it's irritating the cartilage. We move more to the non-impact exercises, including swimming, biking, yoga, even Pilates. Sometimes we have to move towards a cane or walker to offset the joint pressure when patients are walking around. Weight loss should be included as well. The ankle sees anywhere between 5 to 7 times the body weight stress across the ankle joint. So as much weight as someone can get off, it helps relieve the patient's joint of that much stress. Many times with conservative care, we add physical therapy to the program. With physical therapy, it improves upon the ankle motion. A stretching routine is usually instituted as well to keep the fibers at length so they're not injured as easily. We improve upon ankle strength as well as muscles around the ankle strength. We encourage non-impact exercises, but also give patients home exercise programs. We look to decrease pain and swelling with physical therapy. That includes the utilization of electrical stimulation, heat and cold therapies, massage or effleurage, or moving swelling out of the joint space. Along with conservative care becomes brace options. Shoe modifications, non-fixed supportive braces, and fixed supportive braces are all entertained. Shoe modifications include inserts, rocker sole shoes, or even orthotics. With non-fixed supportive braces, that includes lace-up ankle braces as well as compression wraps. With fixed supportive braces, that includes posterior splints and circumferential braces. With a fixed supportive brace, it's usually more binding or controlling of the ankle joint. These are some pictures of non-fixed supportive braces. To the left-hand side is a cloth lace-up ankle brace. The generic term for that is called an ASO brace, as you see by the name on the brace itself. A plastic hinge brace is another form of a non-fixed supportive braces. When we move towards fixed supportive braces, they tend to be more rigid and more confining. This is an AFO, or an ankle foot orthosis type of brace on the left-hand side, otherwise known as a posterior splint. These are all braces that are typically going to be custom made for the patient. When we move to the right-hand side of the screen, this is considered a circumferential brace. It's made out of leather. It may have some struts or some metal strapping to it, but also laces up. It's very rigid leather, and we typically call this an Arizona type of brace. When we talk about shoe modifications, that include rocker bottom shoes or a wide shoe. Sometimes we'll place a heel lift, as you see on the picture above. That allows the ankle to be lifted up so it doesn't go through a range of motion where someone who has heels, where someone doesn't have spurs that form the front part of their ankle, so they don't hit as much. It makes them more comfortable. On the bottom picture, a rocker bottom sole shoe allows the patient to roll through their ankle a little bit easier than a rigid sole shoe might. When we move on to surgical treatments, usually we exhaust the conservative care. Options when it comes to surgery include arthroscopic debridement, arthrodesis of the ankle, otherwise known as a fusion of the ankle, versus arthroplasty. Arthroplasty is a joint replacement. Arthroscopic debridement is used for early stages of arthritis, or in certain instances where a patient may have an osteochondral lesion. Osteochondral lesions, osteo means bone, chondro means cartilage. They have a bone cartilage lesion where they've injured an isolated area of the ankle bone. The cartilage becomes separated from the bone, and the fluid gets pressed into the bone, causing pain, discomfort. It's an isolated form of arthritis, but if not treated, it can give patients pain, discomfort, lead to further arthritis. When it comes to arthrodesis, or a fusion of the ankle joint, that's a time-tested fashion of taking care of arthritis. But unfortunately, with the ankle fusion, it leads to removal of the joint motion, which adds more stress to other joints around the ankle. It's used with advanced arthritis. There are good outcomes with it, with long recovery from surgery, however. With a joint replacement using ankle arthritis, it replaces the joint with an implant. It preserves the joint motion, but the implant may loosen or fail over time. This is a picture of an ankle arthroscopy. The nice thing about ankle arthroscopy is an outpatient surgical procedure. With ankle arthroscopy, it involves 2 to 3 small portals or incisions that are created to allow instruments to go into the joint space. We can then visualize in the ankle joint of some normal cartilage, but also some inflammatory tissue on the right-hand side, indicative of synovitis. When that gives patients pain, discomfort, we can remove that inflammatory tissue after conservative care has failed. With ankle arthroscopy, we also can visualize the osteochondral lesion, or loose bodies, or isolated forms of arthritis. On the left-hand picture, we're seeing removing loose cartilage in the joint space and then preparing that bed for healing as we make small little holes in the bone, which is called a microfracture, to stimulate the bone to bleed, which will fill in the defect with fiber cartilage, trying to slow down the arthritic response. When it comes to ankle arthrodesis, or the fusion, typically this is where the joint has advanced arthritis, and what you do is you make abutting surfaces come together and you fuse them with screws. This takes approximately 2 to 3 months for this to heal, but it does a very good job of controlling their pain. However, it takes away the patient's motion and adds more stress to other joints around the ankle joint. These are X-ray findings of an ankle fusion as well, showing the hardware crossing over the ankle joint, holding it together until the bone heals from the shin bone, the tibia, the roof of the ankle joint, to the ankle bone proper. With an ankle fusion, patients will always walk with an altered gait and a shorter leg to a certain extent. The success requires joints below and in front of the ankle to be normal. There's 100% of arthritis at about 20 years in other joints. So this procedure will lead to arthritis at other joints in approximately 20 years. The fusion rate is approximately 83% of the time. That means 17% of the population has an ankle fusion, not very happy with it because it may not heal all the way, or it may have to be revised. The average healing time is between 17.5 weeks for a solid fusion. Some patients do have some residual discomfort between 8 to 20%. And bad news is some people have dysvascularity because of smoking typically, and they may end up with an amputation. Smoking is not a good thing when it comes to ankle arthritis because of allowing the fusion to take place or implant to be placed. When it comes to ankle fusion, there are certain complications that can occur as well, including a malunion, which is described as being the ankle put together but not in the right spot, versus a non-union, where the ankle's put together but it just didn't heal. Both require further surgery. When we move on to ankle arthroplasty, this is the crux. This is what we want to talk about tonight, because this is a new way of treating arthritis. However, it's been very popular in the last 20 years. These are two different implants to replace the ankle joint surfaces. The one on the left-hand side is called a star. The one on the right-hand side is called an infinity ankle replacement. Both of these implants are designed to maintain certain biomechanics of the ankle, specifically motion. With ankle arthroplasty, we replace the joint surfaces with two metal components, and then a plastic spacer, otherwise known as a polyethylene spacer, goes between the two metal components. With the implant on the left-hand side, the polyethylene is designed to be pushed into the joint space, but it's not fixed to any of the metal components. So it's free bearing, so it has motion that goes along with it. However, on the right-hand side, the infinity, the polyethylene is fixed to the tibial bearing, which means it's stabilized to the bearing. It doesn't float around. So technically, that may have a little more stress applied to it. This is a cartoon showing ankle arthroplasty, reconstruction of the joint surfaces. This allows for the motion to be maintained in the joint space. It relieves the patient of pain, but also takes away stress to the other joints around the ankle itself. This is an X-ray finding of ankle replacements. The small little metal wire that you see between the two metal components is actually a wire within the plastic bearing that allows us to know where the bearing sits. With ankle arthroplasty, we have to be very concerned about the wounds. The wound is typically the weakest part about the whole procedure, so we're very cautious about the wound and how it's taken care of. Therefore, patients who have neuropathy or those patients who have a significant smoking history are not very good candidates for ankle replacement. Infections are always a concern with any type of joint replacement. The parts do wear down over time. The polyethylene typically wants to wear down or thin out. There can be polyethylene debris within the joint space as well. Sometimes there can be cysts that form around the metal components. These are things we look out for as we follow patients after surgery. Good outcomes do require surgeons that's skilled in putting an ankle replacement in. Typically, we recommend an orthopedic surgeon. This picture shows the pluses and minuses of arthroplasty versus arthrodesis. On the left-hand side, the joint replacement allows motion at the joint. It provides predictable pain relief. It can correct significant deformities of the ankle joint secondary to arthritis. The patients have moderate non-weight bearing time, anywhere between 2 to 6 weeks. There's probably a 6% revision rate at 5 years. However, we have recent studies that show over 90% of ankle replacements can last up to 15 years. And it depends upon the patient and what the activities they like to participate in with an ankle replacement. We usually recommend low stress and low demand exercises. When it comes to a fusion, once again, it locks the ankle joint in a fixed position. It provides predictable pain relief and corrects significant deformities of the ankle, very similar to an ankle replacement. There's a prolonged non-weight bearing time after surgery, anywhere between 2 to 4 months, to allow the bones to fuse together. There's a 10% non-union rate, but it may lead to arthritis to other joints besides the ankle joint. It is fairly well accepted for an ankle replacement by all academies of the foot and ankle world, including the American Academy of Orthopedic Surgeons and the American Orthopedic Foot and Ankle Society. It's utilized by over 85% of best orthopedic hospitals in the United States, and it's rapidly becoming the procedure of choice for ankle arthritis. Most insurance companies do cover it. There are some insurance companies in different states that may not, and that should be followed up with your surgeon. As a position statement, the use of total ankle replacement for the treatment of arthritic conditions of the ankle. This has been put out by the American Orthopedic Foot and Ankle Society. That ankle arthritis is a condition that can result in substantial pain and dysfunction. The American Orthopedic Foot and Ankle Society supports the use of total ankle replacement as an option for the treatment of ankle arthritis that has failed conservative management in select patients due to its demonstrated improved outcomes in multiple peer-reviewed publications. So in summary, there are several types of ankle arthritis, but all have cartilage loss as the main problem, in addition to pain and dysfunction. Arthritis is painful but treatable. There are a variety of treatment options. The first step toward recovery is a review of your conditions with your physician. You need to be able to sit with your doctor and talk about your options, including conservative care all the way up to surgery. Patients a lot of times feel comfortable looking online, but be careful of the source of your information. Always bring your questions and your concerns with your surgeon. If you'd like to have any follow-up with myself, you can call for appointments. This is my staff. This is my team. Morgan Hatton is my executive assistant. Bree is my medical assistant. Melissa Spencer is a physician assistant that works with me as well. Thank you.
Thank you, Dr. Gittins. We have a few questions here. The first question is, can you get arthritis from a bad ankle sprain?
The question is, can you get ankle arthritis from a bad ankle sprain? Yes, by far, the majority of the patients these days that we see have a form of post-traumatic arthritis, whether it be one ankle sprain that was bad when they were younger, or if they've had multiple ankle sprains throughout their younger years, which has led to arthritis when they're 40 or 50. So the answer is yes, you can get ankle arthritis from an ankle sprain.
Thank you. How long should I wear an ankle brace?
An ankle brace is a structure designed to give you support. A lot of times with an ankle sprain, with an ankle brace, we put somebody in the brace until we have a chance to be rehabilitating them. So that's conservative care for an ankle sprain. If somebody has ankle arthritis and we put them in an ankle brace, that may be on there for a little bit longer. The hope is to be able to rehabilitate them from their pain, discomfort, and be able to wean away from that ankle brace as long as they have stability and strength of their ankle without signs of buckling or giving way to their ankle. So when it comes to arthritis brace, that might be a little more subjective.
How long would you have to wear an ankle brace? Like, long would you wear it for daily wear? How many hours?
Yeah, an ankle brace you can wear as long as you want to, or as short as you want to. It's there for your pain and discomfort. A lot of times I don't want someone tripping on their foot because their ankle hurts so much, or they have restriction range of motion. So our brace gives them that support. It takes them the stress and strain away from their ankle when they're walking around doing things. But you're not bound to the ankle brace for a certain amount of time. You can wear it as much as you want to, or not.
Thank you. Are there particular shoe types that are beneficial for arthritis?
There are probably more shoes that are not beneficial for arthritis, like a high heel or a sandal. But typically, any type of laced-up leather tennis shoe is an appropriate shoe. Some of the mesh shoes work out just fine as well.
Can you move your ankle at all if it's fused?
Technically, no. Your ankle's not moving if it's fused. Now, you can get some motion across your midfoot, but that's not what God intended for that joint to do, is a function of an ankle. And that's why with an ankle fusion, eventually you'll have motion to other joints that will mimic ankle range of motion, but it will wear down those joints and lead to arthritis of those joint spaces over time.
Who is a candidate for ankle replacement?
Anybody that has typically ankle arthritis is a decent candidate for an ankle replacement. There are certain people that are not good candidates for arthritis. People who've had previous infection to the joint space we have to be a little careful with. It used to be that we said people who had ankle arthritis who had a previous infection, they were not a candidate because we were afraid of that ankle replacement becoming infected as well. There are certain things we're doing these days to try and get around that. So it's not a definitive no. Diabetic patients we have to be concerned about because of how well they heal when it comes to surgical procedures. Again, the wound is the most precarious part of the whole surgical procedure. People who have neuropathy, if they can't feel their foot very well, they are usually not a very good candidate for an ankle replacement. We have to be careful with patients who have soft tissue considerations, meaning some patients have very, very thin skin. They don't have a good vascular supply over the top of their ankle. We have to be concerned about the wound healing. Patients that smoke, once again, we have to be very careful because of their healing capacity. These are the patients that we're concerned when it comes to ankle replacement.
Can I run with an ankle replacement?
Technically, you can run. It's not advised that you run because it's an impact type of sport, and that can be very stressful to your ankle replacement. With ankle replacement activities that you can do include bowling, doubles, tennis. You can do light activity, but running or jogging we usually do not recommend you do.
If I get an ankle replacement, will my pain be gone?
That is the goal. The goal of surgery for an ankle replacement is to, as I tell my patients, to improve upon your pain. I can never sit in front of someone recommending an ankle replacement, tell them you won't have any pain whatsoever, but that's our goal. We also want to restore function to your ankle. We want it to be able to move so you can walk, so you can do some activity throughout the day, or even light activity, as we mentioned before, without as much pain.
Can you go from fusing the ankle to an ankle replacement?
Yes, you can. It's a little bit more difficult because the ankle's been fused previously. Well, if the ankle's been fused previously, and then you go put an ankle replacement, and then you expect motion to occur, that's fine for the joint services, but all the soft tissue structures around that ankle may not want to move very well. That includes the tendons, the ligaments, the neurovascular structures. They were fused at one point in time. They weren't moving. Now we're asking them to move again. It's very challenging.
That was our last question. Are there any additional questions? Thank you very much, Dr. Gittins.
Thank you.
Thank you to the participants for joining us for tonight's webinar. Our next webinar will be held on August 1st. Enjoy the rest of your evening and good night.